Thank you very much. Now, whenever we consider SICS, in the SICS, the important thing we must keep in mind is that SICS is a type of surgery. It is not that it is an inferior surgery or phaco is a superior surgery. Any type of surgery what we do, in that we should be confident that this surgery is really a cataract surgery. And if you see the statistics, we operate near about 70 lakhs patients every year in India. Out of that, 42 lakh surgery are done by SICS. It means more than 60% surgery today also in the era of phaco we are doing by SICS. Only thing is we always feel guilty, suppressed, inferiority complex that we are doing SICS. Of course it is not. SICS is one of the type of surgery and it gives the result equal to phaco. Also you can go for the premium IOLs. We are now discussing so many premium IOLs, and you can also go for the premium IOLs when you are doing the SICS. So in the SICS, premium IOL is 100% possible. So that this course will tell you that how the SICS helps you in the management of the cataract, and after that management of the astigmatism, and also the patient is willing, you can go for the premium IOLs. Now when you want to go for the premium IOLs, what is required? The requirement of the premium IOL is the astigmatism, where you must reduce the astigmatism, and reduction of the astigmatism normally it is the tunnel. As the size is large, it creates the astigmatism. And this presentation I am presenting to you how to avoid the astigmatism and how to reduce the astigmatism. So here you can see the optimizing problems. See, these are the different problems. When we are optimizing, you can have these different types of shape, and because of that it is very difficult to optimize. You have got so many axes, so many angles, and then 360 degree. So because of that, then there are so many problems, and then how to go ahead. So first of all is here we will have to use the anesthesia, and there we are using now topical, but yes, we are there also using peribulbar or subconjunctival injection. Then the post-operatively, yes, again we will have to see the course here in the SICS is slightly longer than the phaco, and astigmatism that I am going to speak to you, and the intraocular lenses. So this is what we have divided the course. Now here, yes, we can, topical is not much possible because incision is scleral, but yes, you can give the subconjunctival injection where you are operating, and that can help you in the anesthesia. Then once you see this manual SICS, it is possible to do by the topical, but I will always say that instead of that you go for the local injection. And then you will have to check properly whenever you are operating a patient, and you know the cause of pain in the surgery. And once you know that, the zonules you stretch, sudden inflation of the anterior chamber, nucleus delivery, and iris touch. These are the 4 reasons where you get the pain when you are operating. And then you can see all the steps is done in phaco, and topically can be done in SICS, because all these steps are done in phacoemulsification also. So now I will show you the different. Now see, on one side I am showing the phaco, where I am taking the incision, and here in SICS also I am taking the incision. Now if you see the extension of the incision, in SICS incision is slightly larger and in the sclera, and in the phaco it is in the cornea, and incision is 2.2 to 2.8. And when you see this, see now when I am going in, see the opening is, now here the opening is only 2.8 millimeter, and here we are opening 5 millimeter minimum. So this is what is the difference between this, but this can be managed by the subconjunctival injection. Now the hydrodissection, once you see this in both places, it means in the phaco also, in SICS also it is required, and that we are doing it. See, this is the hydrodissection I am doing, and see there also in the SICS the hydrodissection is done. So again you see the case where I am doing both, can see hydrodissection in the phaco, it is required. It means whatever the pain is there in phaco, same pain is there in the SICS. It is not a different type of pain in SICS, and because of that, only the local injection where I have made the scleral tunnel, or inside you can give pinocan, one injection of pinocan, so that iris touch will not have much pain. So, and that will help you. Now see the IOLs, yes, you always, what you do is, everything is done, but here foldable because the incision is small, and here we can put any, you can put rigid, or also you can put foldable IOL. Only whenever you are putting the foldable IOL there, you will have to take care of, now this is not foldable, but once you are putting it, then you will have to take care of the astigmatism. And if you are taking care of the astigmatism, then you can inject the foldable IOL in the SICS also. So I think the premium IOL, I have compared the steps so that you will understand that yes, we can, all the steps are similar except large incision, and other steps are same. So the pain will be similar in the both. Now post-operative course, you can see the problems. See, post-operatively foreign body sensation is there, and modification you can have cover the wound by the conjunctiva. So always remember, if you cover the wound by the conjunctiva, patient will not have the pain. So this is very important. At the end, you remove your speculum and then repose the conjunctiva. And once you repose the conjunctiva, patient will not have any pain, or you can give the subconjunctival DEXA. Eye patch with topical, you may not pad, remove early. If you want a patient to go home, keep a patient for 3 hours with a patch. And after that, you can discharge the patient by removing the patch. It is possible. And the refraction, now refraction can be, in phaco also we are doing refraction after 4 weeks. And in SICS also we can do refraction after 4 weeks. Now the astigmatism, see what happens. This astigmatism is calculation based on the length of the incision. You know, it is, you can say, equal to the cube of the length. It means if it is larger, more than 3.2, then cube of the length, it means 4 millimeter incision is there, then the astigmatism is 1 diopter. If it is a 6 millimeter, then astigmatism is approximately 4 diopter. And so, whenever you are going for the incision, here your incision should be 4.5 to 5 millimeter, not 6. So reduce the astigmatism, the incision length should be less. So that is important whenever you are doing the SICS. And once you go for the 8 millimeter, then the astigmatism is 8. So here it is very difficult. So always remember that whenever you are taking the incision, their incision should not be more than 5.5 millimeter. But internal incision can be more, so that you can make pockets, and pockets will not take part in the astigmatism. So pockets are more important whenever you are doing such type of SICS incision. Then now see the modification. Yes, we can do the modification of the incision and the position of the tunnel so that the astigmatism can be reduced. So we have got the tunnel. So we do the, can say the arcuate incision to reduce the astigmatism, but here we can do it the tunnel position. The astigmatism induces the against the rule astigmatism, then the superior temporal with the rule astigmatism. Then the lead pressure effect is there, then the no pressure effect is there. And then the near vision, visual axis, away from the visual axis we are doing, and induces the more astigmatism, and the temporal reduces the less astigmatism. So that is what happens in the incisions. So then what we can do? The preoperative workup is very important whenever you are doing SICS. We do all type of workup in the phaco, and we never do any workup in SICS, because we always feel in our mind that SICS is inferior surgery, and because of that we are not doing any you can say the workup for such type of patient. Now here see the autokeratometry, yes, you can go for that. Optical biometry, you do it properly, optical. Yes, Kamalji Singh sir, please come on the dash. Then the topography. We are not doing a topography in the cases of the SICS, because we are thinking SICS, oh yes, SICS is done, only SICS is done, not doing any type of workup before that. And because of that, this SICS is not gaining popularity in the people. Now see this. Continue. 5 minutes. So now this is the, provide the steep and flat axis. So why we should do this? We must know which is the steep axis, which is the flat axis. Please, Kamalji sir, please. Then what happens? You must know the previous glasses. Then the current refraction, if possible, if cataract is less than 1 or 2, you can say, then the aberrometry, can see eye trace also you can see. But here what happens, every investigation is done for phaco and nothing is done for the SICS. But both places you are doing the cataract surgery. So whatever you are doing the phaco, you must do the investigation, same investigation to the SICS. Now see here, you can see the astigmatism here, it is can see, in the axis you will see 114, and the 43 and 45 is the T1 and 2. So once you know this is the astigmatism there, then what you can do, if it is possible, you can take the incision at the axis here now. See the axis 43, 114 can go to the steep axis and see 114, and the incision is planned there. You can't plan incision in the inferior portion, but yes, you can plan the incision in 114 degree, and once you plan there, then can see this, the astigmatism can be reduced. Now see the actual case done. In this, whenever the astigmatism is like this, and here now see, you can go to the steep axis here, and after that, only see the conjunctiva properly. See, it is very important to repose the conjunctiva. See here, the incision is taken, and when the incision is taken here, see, always this incision, I will show you how much the incision is, so that you will understand how to reduce the astigmatism. Now this is the incision, and you see now, on other side, this is Dr. Ragini operating. See here, in the same plane, she is a left-hand surgeon, same plane, now see, and then there is can see this, and here again you will see extension. Now extension is done in the pockets. So internal opening is 7 millimeter, outside opening is 4.5 millimeter. It means outside opening is less, and you see here, it is only 4.5 millimeter is the incision, and from that the lens is removed and lens is implanted also, but it is because of the pockets. So scleral pockets are more important in this situation. Now the other thing is extension. Whenever you are extending the tunnel, here you take the astigmatism is much more. Why? Because you haphazardly, because nucleus is not coming, and that time the brain doesn't work. So you go on this side, that side, outside, inside. And the second day astigmatism is +8, +9, -8, -9. Why it has happened? It is because extension was not proper. So whenever you want to extend inside. Don't extend outside. It is not required. And once you extend, because here nucleus which is there not coming in the, you can say, the tunnel. And see why nucleus is not getting engaged? Because tunnel is smaller one. So inside opening is more, and once it is more, then that nucleus will get the engaged. And then once it is engaged, once you see that, you can say, edge of the nucleus from the tunnel, the nucleus is come out. Only edge is seen and nucleus can come out. So that is what extension is very important. And now here the intraocular lenses. Yes, can you implant premium? Yes, you can implant premium. Yes. And here you have seen the reducing size of the incision, and any type of lens you can implant. And then you can see the astigmatism. Here you will see the patient when it is there. And here you can see the astigmatism is 4.5. After that also, if you implant the astigmatic lens, that definitely will work. So it means it is not that you will not implant toric IOL in SICS, yes, but you will have to calculate what is the surgical induced astigmatism by you. And if you know that, how much you have neutralized by the incision, how much you are going to neutralize by the lens, and then you can implant such type of lenses. And that definitely go for the premium IOLs. And the astigmatism, it is 1.3 diopter is reduced, and you can go ahead and you can see this now in the both places. You can see the astigmatism, and here you can reduce it. It means it is possible, but for that you must calculate. And once you calculate, then astigmatism can be reduced, and you can use the astigmatic lenses, that is toric lenses in SICS. And so SICS outcome can be optimized with minimal modification. So modification should be minimum. You must think that this is a phaco surgery, and in properly you can do it. Then proper evaluation of the preoperative parameters, and the knowing surgeon own surgical astigmatism can be useful tool for the reducing astigmatism. You must know how much is your astigmatism. The bad endothelial count, black cataract results in better and quicker post-operative outcome with SICS. So all these black cataracts, SICS results are excellent. SICS is a premium surgery, and we need to keep updating, modifying it to unmask its hidden potentials. That is what I want, and I think he will do it. Thank you very much. Thank you very much. Now I will call upon Dr. Agini, and she is going to